Good afternoon and welcome everyone to Wednesday Wellness, a free live educational series brought to you by Trinity Health. We are thrilled to have you with us today as we dive into the important topic of kidney wellness. Before we get started, there are a few housekeeping notes. Your cameras and microphones have been turned off to ensure a smooth experience. If you have any questions during the presentation, we ask that you please use the Q&A chat feature located near the bottom of your screen, and our presenter, Dr. Hoffman, will address these questions at the end of the session. Lastly, today's webinar is being recorded, and a link to the video will be sent to you via email in the next coming days. And without further ado, it is my pleasure to introduce nephrologist Dr. Michael Hoffman.
Thank you. So anyway, I'm going to talk to you today about kidney health. Again, it's a topic obviously near and dear to my heart, and hopefully I will show you some importance of kidney function and maybe even give us some tips about what we can try to do to keep our kidney health as we go through life. This is just a quick outline of what I plan to do today. I'll talk basically about the kidneys themselves, the anatomy of them. Just briefly, I'm going to touch on the physiology of what they do. We'll talk a little bit about measures of kidney function, and then I'll talk a little bit on some of the causes of kidney disease, and to understand it's not a comprehensive list, but again, a good start with some of the more common ones. And then what is chronic kidney disease, talking about the classification. I'll show you some of the costs associated with CKD and how that plays into our societal costs and why that's so important to maybe try to work on prevention. We'll talk about CKD screening and then have a conclusion at the end to just go through questions. So, and forgive me if I have made this maybe too simple, but I took the assumption that maybe some people don't even completely understand where the kidneys are and what they do. So the kidneys are located in the retroperitoneum, which means that they're behind our intestines, up underneath the rib cage in kind of a protected spot. We have two kidneys, one on the left side and the right side. These kidneys filter our blood and fluids, and when we make urine, that comes down these tubes called the ureters that come to our bladder, which is kind of our storage area, so that we can store that produced urine, and then some time later, when we have a little time, we can run to the bathroom, and that's how we empty out the urine that we have produced. Each kidney is about 150 grams in size. It's about 10 to 12 centimeters, which basically equates to a size of a closed fist. So that gives you a pretty good idea. Within the kidney, we have these units called nephrons, which are things that help us filter out waste products. And each kidney has about 1 million nephrons at birth. And ideally, we want to try to preserve as many of these functioning units through our lifetime so that we can maintain normal renal function. As I talked about, the nephron is that filtering unit. It's got multiple components. We talk about the glomerulus. That's the actual filter. That's that blood interface where we actually produce a certain amount of liquid to come across into this we call filtrate that comes down into the proximal tubules, or basically the early part of the kidney. And in this area, we have very avid sodium and electrolyte reclamation as well as water. It dips down into the deeper parts of our kidney into what we call the loop of Henle, and then returns back out to our distal convoluted tubule, where we have more regulation of electrolytes and fine tuning of composition of the urine. And then it finally reaches the collecting duct and goes out. Once this comes into the collecting duct, that will come into our renal, what we call pelvis, this area, which then drops into the ureter so it can go down into the bladder and be stored until it's given a chance to come out when we urinate. Kidneys are really important. When you realize they get 20 to 25% of our blood flow with each heartbeat, you realize that that's a very big structure. Kidneys help us control salt and water balance, and this is how we are able to regulate blood pressure as well as our electrolytes. They also are very important. Oops, I've got my own picture window. I got to move this for a second here. And what's important to realize is that they're actively filtering this liquid called filtrate. We do probably about 200 liters of filtrate per day, but we only pee out about 2 liters. So if you really think about this, we reclaim about 99% of our electrolytes and of water, and our body is very good at maintaining that balance so that we can maintain homeostasis. What is also interesting is that our kidneys are very capable, depending on our hydration status, of either making a very concentrated urine. So if we don't drink very much, they can concentrate the waste products into a very small amount of volume. And at the same time, if we drink a lot of extra liquids, they're also good at helping us get rid of that extra water, and they can make a very dilute urine. And that's how they're able to maintain that balance or homeostasis, as we talk about. Our body, if you will, is kind of like an engine. I always kind of use this quick diagram to make us understand that every time that we process food, we have waste products that will come out, and we also have hydrogen ion. And now, if we don't do anything about this, this is going to accumulate in our body and cause illness, and that's what happens with kidney failure. But our kidneys are actually very efficient at helping us get rid of both hydrogen ion and waste products from metabolism, which is coming from our using food for energy. One of the things that's really interesting is that our kidneys are extremely good at helping us get rid of that hydrogen ion, as I talked about. Now, we produce about 100 millimoles of hydrogen per day with normal metabolism. If we were to try to get rid of just that hydrogen ion alone, that pH in our urine would be so low that you would probably burn off the cells of your skin on your urethra or in the urinary tract. But that doesn't happen. And the reason is because our body has gotten very adept by our kidneys to get rid of hydrogen ion. And the way they do that is they form ammonia, and the ammonia then is able to sequester a hydrogen ion, and that goes and forms ammonium. And so what's happening within the kidney, our body takes these hydrogen ions, makes ammonium, and we pee it out. This is how we can get rid of a lot of acid in one day without causing chemical burn. And that's important for us to be able to maintain our pH within our own body. So that's why it's important to have good functioning kidneys to help maintain that. But kidneys do so much more. Kidneys are also important for helping us to get activated vitamin D. Now, as you probably remember, people always tell you to go out and try to get sunlight. That's where we get vitamin pre-D2 vitamin. But there's several steps that have to happen for it to become activated. First off, it has to get transported to the liver. And what happens there is there's a chemical change in the vitamin D so that it becomes partially active, if you will. So we call that 25-hydroxy vitamin D. But the final step where it becomes very active is where it goes to the kidney and we get a second hydroxylated molecule placed on that vitamin D. That now forms that very active vitamin D, which helps us with calcium absorption from our diet, which in turn helps us to preserve bone health. And in fact, it actually even is very critical to help us with our immune system, to keep our immune system strong. And there's some evidence that it also has anti-tumorigenic properties so that it may even protect us a little bit from some cancer formation. So kidneys are obviously playing a big role in helping with this. This is just kind of my diagram showing you again, kidneys making this vitamin D. When we get that active form, we're able to absorb more calcium from our diet, which allows us to be able to push more of that into our bones, helping stabilize our bones. And then that leads to good, strong, healthy bones, which is important, particularly as we reach later stages of life. That becomes compromised when people have chronic kidney disease, and even worse, when people have end-stage renal disease. We know that there's a lot higher risk of bone fractures just because bone health is no longer as strong as it is when you have normal kidney function. In addition, kidneys produce a hormone called erythropoietin. This is the hormone that goes to our blood, bone marrow in our bones, and helps us produce red cells, and that's how we regenerate red blood cells and prevent anemia. So consequently, when patients have more advanced kidney disease, we start to have problems producing enough of that hormone, and it's more likely to become anemic. And anemia obviously can be associated with many other complications. So kidneys are very important for you, as we kind of talked about. We talked about the waste removal. The waste removal is really important because that also helps us with fine-tuning that acid-base balance. In addition, by having blood pressure regulation, and this is happening by us being able to maintain our extracellular fluid balance between having the right amounts of salt and water, so we don't have too much or we will develop high blood pressure and swelling called edema. They're also important for us to maintain our electrolytes. So we talked about potassium, but it also helps us with magnesium, calcium, and other things. And these are really important because basically our nerves function or have conduction depending on having appropriate electrolyte levels. And when these get to be very abnormal, we can have problems with either heart arrhythmias or even muscle strength goes down because the nerves don't function in the normal way. Obviously, vitamin D is important for us to maintain health for our bones, and erythropoietin production is obviously important for anemia prevention, and that actually then turns out to have a lot of help and improvement to make sure that we don't develop cardiac problems. And then obviously drug removal is really important that we don't overdose or get toxic on some of the medications that we may sometimes be prescribed, and we count on our kidneys to help us filter out a lot of those medications, keep them at accurate levels. So let's talk a little bit about definitions. First off, as a nephrologist, we often talk about the nephron mass. Nephron mass is basically the number of functioning nephron units. And again, like I said, we're all born with about 1 million nephron units in each kidney. We normally maintain that number until about age 35. And then we start to have some age-related loss that continues for the rest of our life. But ideally, with having enough kidney function, we should be able to maintain that for the rest of our lives and never require any therapy to replace that. Glomerular filtration rate, this is the rate at which all those nephrons in the kidneys produce that fluid or that filtrate process. And again, it's somewhat difficult to measure without really in-depth testing. We use a measure called creatinine, or that's a byproduct from muscles that's produced at a constant rate, and we can see how easily our kidneys remove it. And by using that, we are able to then usually get an estimation of how much kidney function we have. Now, one thing to be aware of is that creatinine in the blood is not perfect, sorry. It's kind of an indirect measurement of the GFR. Now, it's easy to measure because we produce that every day and it's easy to get in a lab test, but we do know with declining renal function, our body has other ways to get rid of creatinine that will often skew that equation, especially in lower levels of kidney function. So this has led to us using what we call the estimated GFR. And this is basically a number that's giving us the rough idea of percentage of kidney function relative to the creatinine. Now, a normal GFR takes into account a person's age, sex, body size, And what we know is it typically starts to decline with age. The National Kidney Foundation just came out with recommendations as to which equation to use. And now they've been suggesting that we use the CKD-EPI equation to estimate GFR. And again, the reason is that that does not have a race bias. And so that was eliminated from these equations to make sure there's no artificial bias based on ethnicity or race. There's other calculations that sometimes people use, particularly Cockcroft-Gault is another one that we use a lot of times when dosing for medications. And that's just because it was historically the equation that was first used to try to estimate what level of kidney function was safe for certain drugs. But more importantly, most of the time now, when you get lab work done, it will be using a CKD-EPI equation to give you an estimated GFR based on that creatinine for that person. So what causes kidney disease? Well, there's a lot of different things that can potentially lead to kidney disease. Some of the more common ones are either diabetes, so type 1 or type 2. As you are probably well aware, the prevalence of type 2 is much higher in our society as compared to type 1, but both of them are pretty strong contributors to development or risk, at least a risk for developing kidney disease. And I'll talk about that more in some other slides. High blood pressure, again, patients with heart disease. So often people that have congestive heart failure, when the heart begins to not beat as effectively, it decreases blood flow to the kidneys, which can then lead to a secondary injury to the kidneys, also known as cardiorenal syndrome. Again, there are sometimes autoimmune diseases that develop de novo that can affect the kidney. So an example of that would be like lupus nephritis or what we call IgA nephropathy. But these are again stemming from a systemic autoimmune disease, leading then to secondary kidney damage. There are structural causes that cause the kidneys to become compromised. So again, in people that have prostatic issues, so prostate cancer, or men as they get older, the prostate typically gets larger. If they're not able to empty the bladder well, they can cause back pressure and cause kidney problems. Renal cancer, sometimes if that's bad enough that we have to take one of the kidneys out, that can obviously lead to decreased nephron mass or kidney stones that cause obstruction, etc. Sometimes infectious diseases themselves go in and cause damage or cause kidney injury or sometimes permanent damage. So hepatitis B, C, HIV, a lot of these other ones can lead to secondary inflammation in the kidney and lead to kidney scarring and problems. A lot of times it may actually come also from our medications. So things that we use to treat our medical conditions may have the secondary effect of unfortunately affecting our kidneys. So good example of that, chemotherapy. Well, we need chemotherapies obviously to help treat cancers, but often these can be very punishing to the kidneys and end up causing a secondary kidney injury. IV contrast, typically with most contrasted IV studies with one time, that's not usually going to cause a big risk for kidney disease. However, sometimes when people have to have multiple studies or many episodes of repeated frequent contrast exposure, that can sometimes lead them to a risk of having chronic kidney disease or kidney problems, and sometimes prolonged exposure to antimicrobials. So examples are patients sometimes may have an infection that requires many weeks of antibiotic therapy, and that can sometimes lead to kidney problems. But the big one that I talk about, because a lot of people are, at least in the general community, are not as aware, but non-steroidal medications, especially chronic exposure to your ibuprofen, Motrin, Aleve, naproxen, those kind of medicines, can lead to long-term permanent kidney damage. And that's something that we try to raise more awareness of for patients that are needing to take some type of a pain medication. So what is kidney disease? How do you define it? This is basically anything that shows that there's evidence of abnormal kidney function, either by structural or by markers of kidney function, such as like a elevated creatinine, maybe a urinalysis showing either persistent unexplained blood or protein in the urine. And basically, we look at this GFR, that estimated GFR that we talked about based on creatinine. And when we see that it is persistently less than 60 mils per minute, or we have an abnormality suggesting either abnormal blood suggesting inflammation or protein, then we would say that this patient has chronic kidney disease. How do we classify it? Well, we have stages of chronic kidney disease. We base this on the GFR, the estimated GFR. So what you can see at G1 means that a person has fairly normal GFR, but in this scenario, if they have extra protein that's abnormal, suggesting there's some type of kidney problem, then we're going to say this is a G1, and then we look at the degree of proteinuria to help us quantify that. So as a nephrologist, you may see somebody saying, I have a patient now that has G2, meaning the estimated GFR is somewhere between 60 to 90, and then A2 or A3, depending on the degree of proteinuria. And what you see when you look at this is kind of what we call a heat map. These are considered fairly normal and very low risk of having problems. But obviously, with having either increasing protein or lower GFR, our risk of developing renal failure or need for dialysis goes up. And so obviously, the people that are having very low levels of GFR with high proteinuria are at extreme risk of developing need for renal replacement in the future. And this is a big problem. It's been estimated right now that about 15% of all adults in the US have some form of chronic kidney disease. And that translates to somewhere around about 37, 38 million people. We know that this is very expensive. It consumes about 24% of the Medicare budget. And in 2020, that equated to about $130 billion. In addition to the fact that we're spending extra for healthcare, we know that this increases the risk of all-cause mortality. In addition, there's an increased risk of cardiovascular events and cardiovascular mortality, as well as an increased risk for developing kidney failure that requires some type of renal replacement, so ESRD, as well as other adverse outcomes. So to give you an idea, if a patient has both diabetes and chronic kidney disease, their mortality risk is about 6 times higher than somebody that does not have those. And unfortunately, this disproportionately affects certain ethnic groups. So particularly African Americans and Latinos or Hispanics are at increased risk of developing chronic kidney disease. This is very expensive therapy. So to give you an idea, I am a transplant nephrologist. We do roughly about 20,000, a little bit more than that, about 24,000 transplants in the United States each year. Each transplant costs roughly about $100,000 for the transplant itself. And maintenance immunosuppression is going to run you about $20,000 per year to maintain somebody. But that's still much more effective than actually doing dialysis. If we have to do dialysis, if you have to go to a dialysis center, we're going to expect approximately $80,000 per year for your treatment to maintain you on dialysis. So it's clearly much more cost effective to transplant a patient as long as we can maintain that kidney. When we do home dialysis, It's a little bit cheaper. It's about half that cost to maybe 1/3 of the cost. But again, we're shifting the burden of the work to the person and the family to have to do that at home. So again, it's still very expensive care. So sorry about that. What are the symptoms of chronic kidney disease? Well, when a person gets early chronic kidney disease, the symptoms are very subtle. Most of the time, people will notice very little. They may notice a slight development of edema or swelling, may or may not notice that. Sometimes they may notice that their urine looks kind of foamy when they urinate, kind of bubbly. Um, some patients, if they are very, very attuned to themselves, might just say, I feel a tiny bit more fatigued. But usually in the early stages of it, most people are not aware of many symptoms. As this kidney disease progresses, we have a greater risk of anemia, which now leads to a greater risk of having the fatigue. And then again, as our clearance goes down, we can't maintain salt and water balance as well. So leg edema starts to develop, and then hypertension worsens. Now, if people are really attuned to their blood pressure, they may sometimes notice as one of the early things is blood pressures are tending to run a little bit higher. But as I'm going to show you in some other slides in the future, most people are probably not even aware if they're starting to have early hypertension. When chronic kidney disease reaches very, very advanced stages and close to the point of needing dialysis, then the waste products building up start to develop relative toxicity, and people will develop nausea, anorexia, they don't want to eat, appetite goes down. And if they are having trouble maintaining salt and water balance, they will notice they start to get very short of breath, particularly with laying down or doing activities. But at this point, you're now really far gone, and this is not the time that you want to try to start, treat, or prevent. So, what I'm trying to say by this is that the symptoms of chronic kidney disease are kind of subtle. They can just sneak up on you if you're not really paying attention or screening for it. CKD is often underrecognized. Now, this is a study that was done in 2014. And what they did was they looked at primary care physicians and they just said, how many people are doing testing of their patients to make sure that they're accurately testing and screening for chronic kidney disease. And it was kind of impressive that well over 50% of the patients were not appropriately tested. They said around maybe 40% had been tested with no correct diagnosis, and only in the neighborhood of about 15-20% were being appropriately tested and accurately diagnosed. That led to obviously a lot more interest in recognizing chronic kidney disease as a common problem. And there's been a big, strong push for our primary care physicians to be more involved in screening for screening for CKD in patients, particularly patients at risk. So this is just a slide kind of showing that over time we've made improvement, but still, if we look at this for number of people getting appropriately screened, we're still around 30-35% even in this day and age. Clearly much better than what it was, but we're obviously have more work to do to make sure that we continue to screen people for kidney disease. I think the other part that was always interesting too is even when patients go to see their physician, even if they have chronic kidney disease, and this is stages 3 through 5, at most maybe 30-35% of patients are even aware that they have chronic kidney disease. And kind of what you would expect of the majority of those people, they're advanced either stage 4 or stage 5 before they really have any recognition that they're having chronic kidney disease. But we have patients with stage 3B, which is pretty advanced. And if you look at this, at best, maybe 30% of people are 35% of people are even aware that they have kidney disease. So, 60% of people or more could have very advanced kidney disease and have no idea. So that's where it's important to maybe make them more aware of this so that we can try to give them some education and say, here's some things that you could do to try to prevent developing worsening kidney disease in the future. When we look at causes of end-stage renal disease, or what leads people to finally wind up on dialysis, well, by far and away, the two biggies are going to be diabetes and high blood pressure. So when we have a patient that has chronic kidney disease, we have both modifiable risk factors and non-modifiable risk factors. So the non-modifiable ones, that kind of makes sense. If you have a family history of people with kidney disease or kidney failure in your family, I can't change that, but I can at least be aware of it. Obviously, aging, we'd all like to be able to halt that, but we can't really do that. But obviously, the older we get, the greater the risk we have of developing chronic kidney disease. And then obviously, we can't change what race or ethnicity we have prior to that, but we can at least be aware of which groups have a higher risk of it. Now, diabetes may not be completely preventable, but it is treatable. And we do know that clearly by having better control of our diabetes, we are going to lower significantly our risk of chronic kidney disease. In addition, hypertension, and I'm going to show you some slides, is quite prevalent in our population in the United States. And so being much more attentive to hypertension and treatment is going to be also helpful to lower our risk of developing chronic kidney disease in the future. If a person's had a history of acute kidney injury in the past, that is a risk factor for development of chronic kidney disease, and we should be doing everything we can to try to prevent further episodes of AKI, as they will further contribute to long-term risk of chronic kidney disease. And again, as I've mentioned before, trying to counsel people to avoid prolonged non-steroidal usage. That's a very common problem. As a nephrologist, I would see many people that would come in after 2 to 3 years of having some arthritis and been taking those kind of medicines for years, and all of a sudden their kidneys are showing significant damage from that long-term exposure. So I think focusing on our at-risk population. So who should be screened? How should we try to look at this? The things that are really important for screening is to make sure that we have a blood test looking at that creatinine to give us the estimated GFR, and having a urine test. So ideally, in patients that are at risk, you want to do this at least once a year. So patients at risk, diabetes, that's a huge group. If you look at that right now, that's about 38 million Americans in the United States with diabetes. And of this, about 30 million are diagnosed, and there's about almost 9 million undiagnosed. So there is a lot of people out there that need to be finally diagnosed as having that, because they're clearly at risk for progression of their diabetes, which would be leading to an increased risk of developing chronic kidney disease or kidney failure in the future. This is another kind of scary statistic, is that we have 97.6 million adults in the US that have pre-diabetes. And again, obviously this is focused much more on people that are older of age. So this is the type of people that we really should be focusing on regular screening for diabetes as well as for kidney disease. What about hypertension? Well, hypertension is also a problem that's really common in the United States. I don't know if you're aware of this, but in 2017, the American College of Cardiology and the American Heart Association readdressed the definitions of high blood pressure. So it used to be anybody that had a blood pressure of 140/90 or higher was considered hypertensive. But when they went back and looked at demographic studies, they said that's just not enough. We have too much cardiovascular disease, and we should probably be targeting lower blood pressures. So based on that, new recommendations came out in 2017 suggesting that we should be using a blood pressure of 130/80 or lower as our target for considered normal blood pressure. And when you apply that definition to our population, about 48% of adult Americans have hypertension. And what was very interesting when they went back and looked at this, they said only about 20% of those people should you recommend just trying to do lifestyle modifications. And really, we should be looking at more like lifestyle modifications with medications in almost 80% of these people. And what they did find were the people that were on medications, clearly the great majority were not controlled. So we need to be a little bit better about stepping up and trying to be more aggressive with blood pressure control, because lowering blood pressure is going to translate into lowering the risk of chronic kidney disease and heart disease. Oops, sorry, I lost the slide there real quick. It is interesting when people have looked at this hypertension definition. What we do know is that it tends to affect males more than females, and clearly it's something that as we get older, we have a higher risk of developing high blood pressure. So this is why we should be doing much more aggressive screening, particularly in our patients that are after age 40 or more, to detect this early and start treatment. Why is this so important? Well, as I've suggested, when a person has chronic kidney disease, they start having more problems with oxidative stress. It's an inflammatory state, which then leads to problems with progression of our CKD, leading to more risk of anemia, worsening hypertension, and that turns into a risk for coronary artery disease. And this slide shows you, if we look at patients based on level of GFR, estimated GFR, when we look at all-cause mortality, the higher the stage of the kidney dysfunction, or basically, you know what I mean, the GFR being lower, the greater risk a person has of dying, and it mimics exactly what we see for risk of cardiovascular complications or cardiovascular disease. So again, patients with advanced CKD have much higher risk of developing heart disease and heart complications. And this is why we want to try to prevent that stuff. So it's important to kind of understand that chronic kidney disease is kind of like a multiplier. So patients that already have some degree of cardiovascular disease and then get diabetes and then chronic kidney disease, this is the group that's going to have particularly high cardiovascular risk and events. When a person reaches end-stage renal disease, okay, that's when we kind of failed and has continued to progress. This is a horrible prognosis. So just to show you, dialysis patients have about a 4 times higher risk of all death as compared to the general Medicare population when they have end-stage renal disease. The expected life for a person that's now on dialysis is about 1/4 to 1/5 as compared to the general population. And cardiovascular disease is the most common cause of death in these patients, including sudden cardiac death. So the risk of cardiovascular events is about 8 times higher than the general population. And when you have diabetes as your cause with end-stage renal disease, you're about 20 times more likely to pass away. So these are really scary statistics. And this is why we want to try to avoid people getting to end-stage renal disease. In addition, this is very expensive care, as I've kind of showed in previous slides. So lots of reasons why, from our population perspective and from our society, we would like to try to prevent this. So for a person, any person trying to help promote long-term kidney health, what can we do? Well, trying to eat a more balanced diet with more fruits and vegetables, and particularly there's some suggestion foods that maybe have some antioxidant properties, so such as maybe blueberries, pomegranates, etc. Seeds, nuts, legumes are better for us. Getting regular exercise, and we know that that decreases our risk of cardiovascular problems. Trying to drink enough liquids. Now, typically, it depends on what our activity levels are. We may be, if we're outside working in a hot day, we may need to drink more to help replace some of those losses that we have with sweating. But in general, if a person doesn't have kidney disease or heart disease or any other reason to say we need to limit fluid intake, then we should be trying to focus on maybe 65 ounces of liquids per day or more. Obviously, if we have obesity, trying to lose weight, trying to get to maybe a BMI less than 30 would be recommended. And again, avoiding excessive non-steroidal medications, particularly for joint pain or arthritic type pain. It's important to get regular sleep, as that can translate into having more problems with cardiovascular problems and can also lead to greater risk of chronic kidney disease. And again, alcohol, we say very important to just only do that in moderation, because long-term alcohol can have some effects on the kidney and more importantly, can affect your liver. And if the liver becomes significantly scarred or problems with cirrhosis, that in turn can lead to development of kidney failure. When people have chronic kidney disease, we have a new class of medicines that has come out that everybody is very excited about, called the sodium glucose transporters inhibitors. And what these do, it's really kind of interesting. As I was speaking to before, when the kidney makes our filtrate, that fluid that comes out of the glomerulus, that comes into the proximal kidney, and our body then very actively reabsorbs sodium, potassium, and water, and part of it is it reabsorbs glucose. So what they found was that there's this new group of medicines called SGLT2 inhibitors that block the reabsorption of glucose. And by doing that, we actually are able to help control diabetes. We make blood sugars lower, but more importantly, they have some really nice protective effects that help the kidney. So they help us by decreasing salt reabsorption. So they help with blood pressure. They help control diabetes, again, like I said, by losing the glucose in the urine itself. They can help us decrease a risk of developing high potassium. But most importantly, they have been shown to decrease the risk of progression of chronic kidney disease in both diabetics and non-diabetic patients. So these are becoming a huge part of our armamentarium for how do we treat people with advanced or advancing CKD to try to decrease the risk of kidney problems in the future. And in addition, I'll show this in later slides, they've also been shown to decrease cardiac events. So they do multiple things. At the level of the kidney, one of the things that they do is, like I said, by preventing extra sodium and potassium reabsorption, we develop more filtrate, so we actually pee out more glucose, and that actually helps us to have more relaxation in this glomerulus, which is our filtering unit. When people have more advancing kidney disease, we tend to have increasing pressure within this glomerulus, that filtering unit, which is what leads to more damage and more decline in kidney function. And these medicines, as demonstrated by this slide over here on the right, do a very good job of helping us lower that process. In addition, they have been shown, as I was saying earlier, to reduce cardiovascular events. And it's really interesting how they do that. They do this in multiple factors, as we can see. They decrease inflammation. But what we do know is that in more than one study, it has been shown that they reduce cardiovascular disease by approximately 30% in patients with CKD and heart disease. And in patients that have congestive heart failure, they reduce the risk of hospitalization for congestive heart failure about 35%. So these are amazing medications, how much they have helped not only kidney, but they also have advantages for the heart. But it doesn't just stop there. These medicines can help people lose weight. As I just talked about, they can help with cardiovascular risk of mortality and heart failure. They also, believe it or not, can help our pancreas function better. So our diabetics have better control of glucose. They decrease uric acid levels, so we have less risk of developing gout. They slow down the progression of kidney disease. And like I said, slowing this down by a third, that's pretty dramatic results to be able to really halt or slow kidney disease. In addition, they can help us with with cholesterol control, as well as helping us with blood pressure. But it doesn't even just stop there. They've also noticed that it actually helps with liver function. So a lot of times patients that may be having fatty liver or problems with early liver dysfunction can find that these medicines improve that. We know it helps with oxidative stress. And most importantly, we have with renal protection, there's also been studies showing that we have better control of our anemia with using these medications as well. So lots of benefits. And I think as these continue in time, we're going to find more and more obvious benefits. And we're hoping that this may really change the trajectory of people with chronic kidney disease so that hopefully we can slow down the number of people reaching dialysis or needing a transplant. So, in a person with CKD, what other modifications of cardiovascular risk factors can we do? Well, it's really important to talk about stopping smoking. Anybody that smokes has about 4 times higher risk of developing end-stage renal disease or kidney disease, so we should really emphasize that, help get our patients to try to quit smoking. The benefits of exercise, as I talked about before, for anybody are important, particularly with CKD, knowing we have that high risk of cardiovascular disease. And then obviously trying to get weight reduction and optimize our diabetic control. With diabetes, we try to target a hemoglobin A1C of 7 or lower. And obviously, if we can get it lower yet, we're probably going to improve long-term risk for kidney complications. Using lipid-lowering therapy, particularly for patients that have advanced kidney disease, because we know there's such a strong history of developing cardiovascular disease as well. If the patient has had coronary disease, then clearly using aspirin, it's not as recommended for primary prevention. And then trying to get our blood pressure down to appropriate goals and avoiding those things that could make things worse, particularly non-steroidal medication or other nephrotoxic medications. So when does a patient need to get referred to a nephrologist? Because as you can imagine, there are a lot of people running around with chronic kidney disease, and not everybody needs to go to a nephrologist. But if we see a patient that's developed an acute or sudden drop in GFR that's been sustained, they probably need to be evaluated as to what is the cause. Patients with stage 4 chronic kidney disease or stage 5, meaning a GFR less than 30, or patients with heavy proteinuria, persistent heavy proteinuria. These are people that we typically want to take a look to make sure that we don't have something else that we can do to modify that kidney disease and halt it. somebody that has a very atypical progression of CKD, meaning a very either rapid, sudden drop or some other structural thing that would make us say there's something unusual here. Patients that have an abnormal urinary sediment, meaning having a lot of red blood cell casts, or red blood cells that doesn't have a good explanation as to why they're having that blood in the urine, may warrant evaluation at a little higher level. And again, people with severe hypertension that are refractory to treatment or requiring for a more antihypertensive agent, it's probably a good idea for them to see a nephrologist to make sure that we don't have a secondary cause for that hypertension. Because if we can treat that, we can definitely slow down or prevent progression of CKD. Also, patients that have significant problems with either too high or too low potassium may warrant evaluation, or a patient with a recurrent extensive kidney stone history may benefit from seeing a nephrologist, or anybody that's got hereditary kidney disease or a strong family history of kidney disease. So in general, stage 4, stage 5, unless we have one of those other indications that I kind of showed on the last page. So things to do, I think I've kind of talked about this before, but just to kind of reiterate, what can we do every day in our life to try to help promote kidney health? Well, eat a kidney healthy diet, again, meaning more fruits and vegetables, things that maybe have some antioxidant properties. Avoid those prolonged use of non-steroidal medications. Screen for hypertension, particularly in patients with older age groups. Control, obviously, our hypertension, screening for diabetes, as we kind of talked about, that's a very rampant problem in the United States. And then obviously aggressive treatment if you have diabetes. Avoid prolonged or frequent episodes of dehydration. So trying to maintain, like I said, that 65 ounces of liquid intake per day or more. And then regular screening with a PCP for renal disease. So in conclusion, chronic kidney disease is a very common problem affecting a lot of Americans. It's got very serious short and long-term consequences. This diagnosis is often underappreciated, mainly because people don't have a lot of symptoms. Now, we do have effective preventive and therapeutic measures, but unfortunately, they're frequently delayed in when they're started. And the sooner we can start those, the better chance we have of preserving renal function. As I kind of showed earlier, this is a tremendous cost to society and as well as to patients, because this can greatly impact your quality of life and what you have to do for treatment going forward, particularly if a person winds up having to wind up on dialysis. I mean, that's a big burden on life. So I think increasing awareness about the stages of kidney disease, hopefully we can make an impact and try to decrease that risk of associated comorbid conditions by controlling the CKD and hopefully making people healthier for longer in their life. I guess with that, I will end here and see if there's any further questions.
Thank you, Dr. Hoffman. As you mentioned, we will now transition into our Q&A session. If you haven't already, you may submit your questions using the Q&A chat feature near the bottom of your screens. And it looks like we do have quite a few questions already submitted, and we have about 5 minutes left, so we will get through as many as we can. Any of those that we are not able to answer, we will collect and then provide the written answer in the follow-up email that everyone will receive. So let's get started. First one is, why would blood be in my urine? How serious is it?
Blood in the urine?
Yes, why would someone have blood in their urine and how serious is it?
So first off, when we have blood in the urine, it's important to remember 80% of the time it's coming from outside of the kidney. So there's multiple things that could be causing that. That could be something in your bladder, it could be in the ureters. But if it's coming from the kidney itself, that usually indicates inflammation or a breakdown of that blood kidney interface, which is the glomerulus. And that often can signify that a person has a autoimmune or inflammatory condition in there. And if that's untreated, that can progress and that can cause kidney failure. So that's why that's important to look for that. Hopefully that answered that question.
Thank you. The next question is, what about heredity causes kidney disease?
Well, so there are certain hereditary gene mutations that lead to kidney disease. Um, Again, there's a whole host of these. There are some families, so for example, I talked just briefly about like cystic kidney disease. There is a genetic uh, disease that people have called polycystic kidney disease. They have excess cyst formation. In fact, that's the most common genetic disease leading to kidney problems. Um, that is one that your kidney just doesn't handle liquids correctly. It forms cysts instead of filtering all that fluid. And as those cysts grow, they crowd out the regular kidney tissue, and you develop kidney failure. So, but there's a whole host of different genetic things that can happen that put you at increased risk of chronic kidney disease. So again, that's why a lot of times we are having more interest in looking at genetic testing for renal disease, particularly when we have many family members that have something like that. We can often detect that there maybe was a genetic mutation that led to that kidney disease.
All right, this next question is a little bit longer. For someone who is an active 59-year-old female that drinks a lot of water and does not drink alcohol and has had a history of kidney stones over the last few years, they're wondering if you have a recommendation of foods they should avoid or should add to their diet.
So, well, with kidney stones, I mean, I have to qualify that and say I don't know if they've had a workup to find out what type of kidney stones. But that's important because some kidney stones will be modified by certain dietary things, whereas other times it depends on the stone composition. There may be other dietary things that you need to do, and sometimes they can be opposite. One of them would accentuate it, and one of them could make it better. So if a person's had usually more than 2 kidney stones, we do recommend that they follow up with a nephrology doctor or a kidney doctor. They will do a 24-hour urine to see what's coming out in your urine and see is there a way to modify the urine composition, if you will, so that you can decrease that risk of stones in the future. Because each stone that is in there can cause potential damage to the kidney and sure make things worse.
All right, I think this might be our last one. And then again, we will include the remainder of the questions in our follow-up email with the answers. This last one is, I have recently read that vitamin D causes problem with the kidney. Is there any validity to this? And if not, what is a good dose of vitamin D?
Well, I'm not aware that vitamin D causes a problem with the kidney. Um, so you can, I can take the one scenario that if you have excessive vitamin D, okay, and you take super therapeutic doses of it, that can lead to having too much calcium in your blood, and that could give you a secondary kidney injury. So maybe that's what they were getting at. But generally, for most people, and again, what is interesting about vitamin D is it's cyclic. So right now in the winter months, we have less sun exposure. Most people get a relative vitamin D deficiency in our latitude of where we are in the globe. If you're closer to the equator, they have less risk of that. So I typically, recommend for most patients probably taking a vitamin D supplementation. 1 or 2,000 vitamin D3 units over the counter once a day will get you probably to more than adequate levels. And if you have a little extra, you typically are not going to get toxic from that or have other problems. So that's kind of a general thing without knowing blood levels or anything on a patient or a person.
All right, thank you so much. It is now 1 o'clock, so I would like to thank you once again, Dr. Hoffman, for your presentation and Q&A session. And to all of our participants, thank you for joining us, and we hope you have a wonderful rest of your day.